Good morning, everybody. I'm Dr. Lee Axe. I'm from Johns Hopkins. By way of orientation to this session, let me state that we're going to be kind of bouncing back and forth between topics. So we've got some burn surgeons on the panel, reconstructive surgeons, talking about use of lasers in their practices. And then you've got myself and Dr. Grace Snow, who are both laryngologists. We treat laryngeal disease, and so you'll get a version of how we incorporate lasers into our practice. In the operating room, that will be me, and despite the fact that the program lists operating room for Dr. Snow, she's talking about office-based practice. Not a lot of time for each of these brief talks, only about 7 or 8 minutes. So if you don't mind, please try to keep questions to the end. But we will try to leave time at the end of the session for questions. Handouts are available in the mobile app, and speaker bios are available in the meeting app as well. So with that, let's talk about pulsed angiolitic lasers for laryngeal disease in the operating room. And my goals are to provide a quick overview of microlaryngeal surgery in general. Are there any other otolaryngologists in the room besides myself and Dr. Snow? So I'll just kind of orient you to how we're operating on the vocal cords in the first place. Then we'll pivot quickly to benefits on lasers when operating in the larynx, and then talk about the 2 types of lasers that are used in laryngeal surgery with some relevant cases. So this is a general approach overall to microlaryngeal surgery. Endoscopic approaches through the mouth, patient supine upon the operating room table, surgeon behind the table at the head of the bed, reaching this laryngoscope past teeth, tongue, and into the throat, and then reaching instruments through it. So our instruments are about 25 centimeters long, and the vocal cords are only 25 millimeters long. And so we're really aiming for precision. We're aiming to not cause any additional scar tissue to the layered architecture of the vocal cords, because that's how we save function. What it looks like through an operating microscope that we put in place between us and then the patient are these magnified views that allow us to look, for instance, at this cyst so that we can stretch the vocal fold and try to remove diseased tissue, and on the order of fractions of millimeters, try to save as much normal as we can. So this is clearly cold instrument surgery, done with an eye towards removing the cyst from within the right vocal fold. And these are most often benign lesions. We use these lasers for cancerous lesions as well, but the goal even with benign lesion is largely functional. It's trying to improve the quality of somebody's voice. So with that overall approach in mind, why do we use lasers? I like to tell my patients lasers are just a tool. There's nothing magic about a laser in the larynx. There's a lot of, I think, PR around lasers. I think a lot of patients want to know if you're going to use a laser. They get very excited when you say you're going to use a laser. But just like any other tool, they can be used well or they can be used poorly. And one tool isn't necessarily better than another. So with that cyst example, for instance, I wouldn't, in my own practice, have had a role for a laser. To me, that's a cold instrument case. But there are certainly times where we do use lasers, and we're going to talk about that. Lasers in microlaryngeal surgery started decades and decades ago, into the 1950s and 1960s, and initially with the carbon dioxide laser. Some early pictures of those carbon dioxide lasers, and I know people who had worked with the group in Boston, Drs. Vaughn, Strong, and Yako, who first started using carbon dioxide lasers attached to a micromanipulator fired through the laryngoscope to reach the larynx, 400 millimeter micromanipulator and focal length, telling me that initial CO2 laser was the size of a current kitchen refrigerator, that it required trips from the residents assigned to the case to the cafeteria to come back with buckets of ice to pour into and around the laser casing in order to cool the laser during the surgery, right? So clearly we've evolved since then. But a carbon dioxide laser used with a chromophore of water on a micromanipulator, sometimes with the pattern generator helping to determine the spot size and length of incision, is largely a cutting laser. Here there's some right vocal fold disease. They're trying to raise up that diseased epithelium as a flap of diseased tissue, using the laser to make the lateral cut, which then allows them to reflect that tissue laterally. So in our mind, CO2 lasers are cutting lasers and are really good for hemostatic, fine control of incisions, as in this type 1 ELS chordectomy for leukoplakia. But for many of us, myself and Dr. Snow included, we've really transitioned away from carbon dioxide lasers to the pulsed angiolitic lasers. And I think that there are a number of reasons that we've done that. I'll mention that there are largely 3 angiolitic lasers in otolaryngologic practice at this point that are used for this fiber-based photothermolytic effect. KTP laser for a long time had been our workhorse laser at 532 nanometers. Before that, it was the pulse dye laser, and now we're transitioning to the true blue laser because they're supporting it and maintaining it and selling it. The prior makers of the KTP laser for otolaryngology practices, at least, have stopped supporting the laser, and it's tough to get parts, and so we're all transitioning to the other type of true blue laser. But they all have as their chromophore oxyhemoglobin. And all of these fiber-based lasers allow you to bring in the laser on the instrument rather than on a micromanipulator, titrate effect on the tissue by bringing the laser closer or further from your target tissue, but you don't have the benefit of pattern generation. It's all manual control. And as we know with my best attempt to draw pictures that are similar to what I learned from Steve Zeitels, who first pioneered photothermolytic lasers in laryngeal surgery, and he learned from Rox Anderson, it's all about dialing an effect as it relates to cooling of tissue between pulses and selective absorption of your laser energy by the oxyhemoglobin in the superficial layers, the vascular layer, the blood vessels are on the surface of the epithelium of the vocal folds in order to limit scar beneath that layer, okay? So a short pulse, selectively absorbed, followed by a period of cooling, allows the heat to disperse in the tissue before you generate your next pulse. And in this way, you can titrate your laser effect to the oxyhemoglobin without having much thermal effect to surrounding tissue. And in that way, we can try to limit the laser impact on the superficial lamina propria on the vibratory layers of the larynx. So in a choriolentoic membrane model, in a fertilized chick embryo with a circulatory system, you take a fertilized chicken egg, and before it's hatched, of course, and take the egg shell off the top of it, there is actually circulating vasculature in this egg. And then you can use, this was a pulse dye laser at the time, you can use these lasers to target the oxyhemoglobin vessels, and you can try to photocoagulate these vessels and help them modify them without releasing much laser energy. And so this is a proof of principle for these photoangiolytic lasers in the operating room. And as it's used in the operating room, what it looks like is this, right? So a vascular lesion, a varix, this patient had repeated vocal fold hemorrhage, had hoarseness on that basis. Our goal is to get rid of that blood vessel and to save all of that tissue that you're seeing stretched right now. All of that tissue which provides for vibration and voice. We're trying not to cause scar in that layer. And a laser whose energy is absorbed preferentially by the blood vessel rather than the surrounding tissue, pulsed in a way that allows the heat to dissipate so it doesn't build in that surrounding tissue is how we can do it. So these angiolytic lasers in the operating room are used, as I said, for some benign conditions. You just saw one, but we use them for neoplastic conditions as well. Laryngeal papilloma, HPV positive, recurrent respiratory papillomatosis is frequently seen in the larynx and can be treated with these lasers as well. Laser energy absorbed by the pigment. Laser energy absorbed by the chromophore, which is the oxyhemoglobin in the little coilocytic change within the papilloma. And we can do it for leukoplakia as well. So I think that's about as much time as we have. I'll let these surgical videos play as we switch speakers, but I'm going to invite Dr. Charles Holtman up. He's speaking on combined lasers and surgery to optimize form and function. And I thank you for your attention.